Here at CHEST 2015 in Montreal, Thomas Baldrick joined by Dr. Victor Tess talking about managing the patient with pulmonary arterial hypertension, a customized approach. So with new therapies, it really is a customized approach, isn't it, today?
Yes, the treatment of pulmonary hypertension has really evolved fairly rapidly in the last 12 to 15 years. When I started, we only had one therapy that was applicable to most patients, and that was IV prostacyclin. And while it's still considered by many to be the best medication we have for the treatment of the disease, it was so complicated to use that it was limited for the number of patients who could take it. The most recent developments and guidelines have really taken advantage of that, of the newer medications, particularly in the last guidelines, the approval of macitentan and a drug called riociguat, which work in different pathways and have both been shown through different kinds of studies to improve outcomes in pulmonary hypertension. The macitentan improved morbidity and mortality, mainly morbidity, which is i.e. worsening of disease, in a very prolonged study and with remarkably good side effect profile. And it's an endothelin antagonist which you take once a day. The riociguat works through the nitric oxide pathway, and it was shown to improve function as measured by the 6-minute walk and prevent disease progression in both patients with PAH and patients with chronic thromboembolic pulmonary hypertension. So it was approved in the United States for the oral therapy for chronic thromboembolism associated pulmonary hypertension, and it's the first drug to get that assignation. The new guidelines predominantly make a big difference because they focus now on the concept of combination therapy and aggressive upfront combination therapy, and I think that's the biggest change in addition to the newer medications that the new guidelines point out.
How do you think the new guidelines will change the way you treat patients?
Well, I think based on previous data and experience, many of us had already started to transition to very aggressive escalation of therapy, even if we didn't start with upfront combination therapy. And so in that sense, I don't know that it's going to change my practice much, but it certainly does give us the ability to reference the medical literature and show that these combination therapies, which we've long thought were better than individual therapies, are beneficial to the patient, both in terms of how they feel, but also in their morbidity and mortality.
Can you review the major factors that might preclude a PAH patient from elective surgery?
Well, elective surgery in anybody is always a balance between risk and benefit. Patients with PAH are far more complicated because their ability to respond to the stress of anesthesia is limited substantially. They also don't tolerate hypoxemia and increased carbon dioxide levels very well, and the initiation of mechanical ventilatory support, such as when you have a breathing tube put in for surgery, can be a real trauma for a patient with PAH. So for us, the most important thing when we're talking about elective surgery for a patient with pulmonary hypertension is the disease stable, and is it in a stable, acceptable state? A patient who's very impaired and with an advanced functional impairment is going to be high risk for any operation. The pulmonary hypertension will increase the risk of PH, or increase the risk of perioperative complications, but as long as the patient is compensated with an adequate cardiac output and without excessive signs of heart failure, they often can undergo the surgery.
Very good, sir. Thank you for your time. We appreciate it.
Thank you, Thomas.